Good morning. At the outset, let me thank the organizers for giving me an opportunity to talk regarding perioperative glycemic control. Diabetes mellitus is the most common metabolic disorder and affects about 6 to 7% of the population and between 10 and 30% of the inpatient population. There is now overwhelming evidence that both hypoglycemia and hyperglycemia in the surgical patient with diabetes leads to increased risk of death, morbidity, and length of hospital stay. There is now evidence that surgical patients with previously undiagnosed diabetes who develop perioperative hyperglycemia are at an even greater risk of mortality and morbidity compared to the surgical patients with diabetes. Therefore, it is necessary to ensure optimal glycemic control during the perioperative period. An estimated 25% of patients with diabetes will require surgery, and 28% of patients with diabetes are unaware that they have the disease. 5 to 10% of patients presenting for surgery are found to have previously unrecognized diabetes. This is particularly important because patients who are unaware of their diabetes status have higher preoperative blood glucose levels and a higher risk of perioperative mortality compared to patients who are aware of their diabetic status. According to the International Diabetes Federation, the global prevalence of diabetes was around 8.8% in the year 2015, and it's projected to rise to 12% by the year 2040. And it is the leading cause of death globally. In India, it is seen that we have a prevalence of 8.9% of diabetic patients, and we have around 77 million adult diabetic patients in India, and that becomes the second highest number of diabetic patients all over the world. And the bitter truth is that the growth rate of diabetics between 1990 to 2015 was 128%. Now, what is the definition of diabetes, or the criteria for diagnosing diabetes? And this has been put out by the American Diabetes Association. If you have either a glycated hemoglobin level that is more than 6.5%, a fasting plasma glucose that is more than 126 milligram percent, or a 2-hour OGTT of more than 200 milligram percent, or a random plasma glucose of more than 200 milligram percent, you are branded a diabetic. Now, as all of us know, we have type 1 and type 2 diabetes. In type 1, it is actually the activation of the immune cells, which causes an autoimmune response leading to beta cell destruction and beta cell deficiency in the pancreas, leading to diabetes. While in the type 2, it is basically an insulin resistance that develops, causing beta cell dysregulation, impaired glucose tolerance, and beta cell insufficiency, causing diabetes mellitus. Now, whether it is the beta cell destruction or the beta cell dysfunction, it all leads to hyperglycemia, which brings along with it complications. The microvascular complications, which affects the eye, that is the retinopathy, affecting the kidney, the nephropathy, and affecting the peripheral nervous system, causing peripheral neuropathy. The macrovascular complications basically affects the brain, causing stroke, affects the heart, causing coronary artery disease, and it affects the peripheral arterial system, causing peripheral arterial obstructive disease. Now, the management of these patients, the type 2 patients, are with oral hypoglycemic agents like the biguanides, sulfonylureas, the meglitides, the dipeptidyl peptidase 4 inhibitors, and also the SGLT2 inhibitors, that is the glyphosins. Also, we have non-insulin injectables like the exenatide and the liraglutide, which are glucagon-like peptide type 1 receptor agonist agents, and these are all long-acting agents. Now, the management has been shown in this flowchart by the American Diabetes Association. The first line of therapy is metformin, along with comprehensive lifestyle modification, which includes weight management and physical activity encouragement. Now, if there are indicators for high risk, these patients should be started on SGLT2I inhibitors with proven benefit, either for preventing heart failure or patients with atherosclerotic coronary vascular disease or chronic kidney disease. But if cost is a major issue, then sulfonylureas or the thiazolidine thiones are the preferred agents of choice. Now, insulin forms the backbone for treatment of type 1 diabetes. From 1921, with the discovery of insulin by Banting and Best, we have come a long way, and presently we even have inhaled insulin that is marketed as Exubera, which is FDA approved for preventing postprandial hyperglycemia. Now, the different varieties of insulin available are the short-acting and rapid-acting insulin, that is the regular or the Lispro insulin, the intermediate-acting insulin, that is the NPH or zinc insulin, and the long-acting insulin, that is glargine or detamir. Now, from a point of view of managing these patients, we can divide these insulins as basal insulin, nutritional insulin, or correctional insulin. Basal insulin, it controls hyperglycemia when the patient is not eating, and it can be given as a long-acting insulin. Nutritional insulin is also referred to as mealtime or prandial insulin. It helps control hyperglycemia related to carbohydrate intake during your meals. And what we give here is the rapid-acting insulin analogs or the short-acting regular insulin. Correctional insulin, again, is used to counteract hyperglycemia that is above the goal, which again is given as rapid or short-acting insulin. All these are given subcutaneously. Now, if you look at the insulin release, you can see that there is always a basal secretion of insulin, and the peaks are related to your lunch. So that should be the way you treat these patients. You should give them a bedtime dose of long-acting insulin for basal coverage, and for short-acting insulin boluses for covering their prandial hikes in blood glucose levels. So how do you do that? In an average patient, the starting total daily dose is around 0.3 to 0.5 units per kilogram per day. And this is divided into 50% as the basal bolus at bedtime. And the other 50% is further divided into 3 doses. And each of them should be given before meal. And the glycemia recommendations for patients on treatment is that your HbA1c should be less than 7%. Your fasting glucose level should be between 80 to 130 milligram percent, and your peak postprandial capillary plasma glucose levels should be less than 180 milligram percent. Now, suppose when these patients come for a surgery where subjected to the stress of surgery and anesthesia, it alters the finely regulated balance between hepatic glucose production and glucose utilization in the peripheral tissues. So what happens here is that there is a counter-regulatory response of increase in the catecholamines, the glucagon, cortisol, and growth hormone. So cortisol, what it does is it increases the production of glucose within the liver, it causes gluconeogenesis, glycogenolysis, and the glucose output is increased. Simultaneously, the catecholamines increases the glucagon production from the pancreas, and thereby it inhibits the release of insulin from the beta cells of the pancreas, and there is reduced insulin production. Simultaneously, the stress hormones act on the adipose tissue, causing increased lipolysis, and there is increase in the free fatty acid production. These free fatty acids inhibit the insulin-stimulated glucose uptake, and thereby you have a relative insulin resistance along with an increased glucose production leading to hyperglycemia. So what are the targets that we aim for glycemic control? Well, the goals of glycemic control are maintenance of fluid and electrolyte balance, avoidance of hypoglycemia, avoidance of marked hyperglycemia, and prevention of ketoacidosis or hyperosmolar states. Now, the perioperative management of diabetes mellitus can be divided into 3 phases: the preoperative, intraoperative, and postoperative phase. In the preoperative phase for elective surgery, if your the glycated hemoglobin is between 5 and 9, you take up the patient for surgery, whereas anything that is less than 5 and more than 9, you refer to a diabetologist. According to the French Anesthesia Society, it is advisable to refer a patient to a diabetologist in the following situations: that is, a patient with known diabetes with preoperative glycemic imbalance, that is HbA1c less than 5 and more than 8, a diabetic, newly discovered diabetes during hospitalization or during the pre-anesthetic checkup, or a blood sugar level that is more than 300 milligram percent, you have to send them to a diabetologist. Now, the criteria for testing for diabetes in asymptomatic individuals are: the testing should be considered non adults who are overweight, that is a BMI more than 25, with additional risk factors like physical inactivity, first degree relative with diabetes, women who have delivered a child more than 4 kilogram, baby more than 4 kilogram, hypertension, and history of cardiovascular disease. Now, in the absence of the above criteria, testing for diabetes should begin at the age of 45 years. Now, the ADA recommends that you take the ADA risk test for type 2 diabetes. It's a questionnaire with 7 questions, and if you have scored 5 or more, you are at risk for developing type 2 diabetes. Now, all these patients should undergo a minimum pre-anesthetic checkup. The minimum assessment should involve questioning their signs and symptoms of heart damage, and whether the patient has any signs of gastroparesis like bloating, nausea, vomiting, abdominal pain, and reflux disease. In such cases, you should suspect that these patients are full stomach and they're at an increased risk of aspiration. In case of the heart, we should be looking whether these, because of the risk of silent myocardial ischemia that these patients can develop, if there is a major surgery or the revised cardiac risk index is more than or equal to 2, with a functional capacity that is less than 4 meds, always these patients should undergo tests for ischemia, and specific management to reduce the risk should be taken. Also, these patients are at the risk of developing the myocardial injury after non-cardiac surgery, that is MINS. And so we should be very careful when these patients come in the postoperative period. Also, tests for cardiac autonomic neuropathy should be carried out. And if there are 2 or more abnormal tests, then these patients are are prone for hemodynamic risks. That is, they could have a labile hemodynamics during the intraoperative period, and also they can cause serious arrhythmias. So we should consider adequate peri and postoperative monitoring, especially in a high dependency unit. Now, coming to the difficulty laryngoscopy, there is an incidence of around 30%. This is due to non-enzymatic glycosylation of collagen and its deposition in the joints, leading to limited joint mobility syndrome. It can get deposited in the atlanto-occipital joint, leading to reduction in the extension of the neck. It can get deposited in the temporomandibular joint, leading to reduction in the mouth opening. Now, the collagen glycosylation, it starts in the interphalangeal joints, as shown in this picture of the 4th and 5th digit, resulting in the patient not able to approximate the palms and the fingers, the hands, and this is the positive prior sign. Now, the degree of interphalangeal joint in all men can be objectively assessed by scoring the ink impression made by the palm of the dominant hand, that is the palm print sign. And this appears to be most sensitive, 78%, and 89% specific in prediction of difficult laryngoscopy in diabetic mellitus patients, as shown in this study done at the Regional Cancer Center in Toronto. Now, the evaluation of cardiac autonomic neuropathy should be done effectively. You should look for the heart rate variation with deep breathing, the heart rate response to standing, Valsalva maneuver, and BP changes with standing. Hand grip dynamometer should be used. The BP changes with standing. If there's a fall in systolic blood pressure more than 20 and a fall in diastolic pressure that is more than 10, it is suggestive of cardiac autonomic neuropathy. Coming to the Valsalva maneuver, you can find that there is an absence of the overshoot of blood pressure during the phase 4. This is absent in patients with cardiac autonomic neuropathy. And these patients should be noted, and these patients can cause problems during the perioperative period. Now, what do you advise these patients regarding their drug management? The oral hypoglycemic agents should be stopped in the morning of surgery. The SGLT2 inhibitors should be stopped 3 days before surgery, because there is a risk of euglycemic ketosis in these patients. Now, coming to the insulin, if the patient is on an insulin pump, you decrease the basal rate by 20% at midnight before surgery. And if the patient is on basal bolus insulins, if the basal insulin is a long-acting insulin, the evening prior to surgery, you reduce the dose by 80%. And on the morning of surgery, you reduce the dose by 80%. And nutritional insulin, you hold on the morning of surgery. Now, coming to the anesthetic drugs and their implication for anesthetic management, the neuromuscular blocking agents like choline should be better avoided, while the non-depolarizers should be selected on the basis of the present hepatic and renal function. Midazolam should be given by intravenous infusion, and it can decrease your sympathetic activation and decrease your serum ACTH and cortisol levels. Opioids should be used cautiously. Fentanyl is the preferred as the analgesic agent. Alpha-2 agonists like dexmedetomidine and clonidine, they help in attenuation of the stress response by decreasing ACTH and cortisol secretion. The halogenated inhalation agents like halothane, isoflurane, and fluorine, they inhibit the release of insulin, and they can also cause negative inotropic effect in the diabetic patients. Propofol should be used judiciously for sedation in ICU, as prolonged stay of diabetics in ICU can cause reduced ability to metabolize the lipids. Now, regional versus general in diabetic patients, till date, there is no published evidence for establishing the safety of one anesthetic technique over the other. Regional anesthesia should be preferred wherever feasible to avoid the complications associated with general anesthesia, such as a difficult airway due to stiff joint syndrome. Regional anesthesia has advantages of decreased stress response, decreased blood loss, minimal risk of thromboembolism, and early resumption of oral intake and preservation of hypoglycemia awareness. But what about the potential risks and concerns? Specifically, diabetic neuropathic nerves are harder to stimulate. They are more sensitive to local anesthetics. They may be more susceptible to local anesthetic-induced neurotoxicity. And patients with diabetes are more likely to suffer from an infection when continuous catheter techniques and central neuroaxial techniques are used. So what can you do? You have to use ultrasound in preference to nerve stimulation for preventing physical trauma to the nerves. You can avoid neurotoxicity by avoiding additional local vasoconstrictors to the solutions, and you can prevent infection by using a meticulous aseptic technique, and you can avoid medico-legal complications by having a detailed documentation of any pre-existing neurological damage these patients have. Intraoperative management, hyperglycemia in surgeries of shorter duration with expected hemodynamic stability and minimal fluid shift. You can give 2-hourly subcutaneous correctional insulin along with blood glucose checks. But in surgeries that involve hemodynamic fluctuations, massive fluid shifts, or which are expected to last longer than 4 hours, the blood glucose hyperglycemia should be managed with intravenous insulin infusion. You can use the GIK regimen of Alberti, which is the rule of 10, that is 10% dextrose, 500 ml, 10 units of regular insulin, and 10 milliequivalents of potassium, which is run at around 100 ml per hour. And the issue with this is when the blood glucose level changes, then the level of insulin has to be changed. So you have to change the whole pack and get a new pack. Suppose your blood sugar goes above 120, you should add 15 units of insulin. If it goes below 90, you should add 5 units of insulin. So you have to keep on changing it. So nowadays, people prefer to give the variable rate insulin using the intravenous insulin infusion, using the insulin pump, where it is diluted as 1 unit per ml. And it is run along with a substrate fluid containing glucose. And for resuscitation, we should have for resuscitation, we should have another IV line. This is a subcutaneous sliding scale for giving insulin subcutaneously. Now, fluids run alongside the variable rate intravenous infusion is initially we give 5% dextrose and 0.45% saline with additional potassium chloride at rate of around 1 to 1.25 ml per kilogram per hour to a maximum of around 100 ml per hour, and additional resuscitative fluids if required should be administered over the second catheter. And it's all imperative that we always check for blood sugar at least hourly, and if there is hypoglycemia, treat accordingly. The infusion rate is stepped up according to the increase in blood glucose levels, and if the blood glucose levels decrease, you should decrease the infusion rate. Now, postoperatively, in the postoperative care unit, it's imperative to review the intraoperative hypoglycemic control, and ambulatory patients can be discharged home with the previous anti-hyperglycemic regimen. The non-critically ill patients who are in the PACO, in the case of their poor or no oral intake, you have to give basal plus correctional insulin. While if the patients are with the regular oral intake, the insulin regimen should consist of basal, nutritional, and correctional components. The critically ill patients, when you have to continue them on the continuous insulin infusion with regular insulin, and the transition to subcutaneous insulin is done once these patients are hemodynamically stable with no vasopressor requirement. They have optimal glycemic control with minimal variability and a steady infusion rate in the past 6 to 8 hours. Then the dose is calculated, and it should be overlapped by at least 2 hours. Now, what about the literature? Now, this is one of the earliest studies on glycemic control in critically ill patients from a surgical intensive care unit at Catholic University of Leuven in Belgium, where patients were randomized to two arms. The intensive insulin arm, where the blood glucose level was maintained between 80 and 110. And in the conventional arm, the insulin infusion was given only when the sugar was beyond 200. That is, there they were maintaining between 180 to 200. And 1,500 patients were studied, and it was seen that the survival in the ICU was better in the patients who were in the intensive arm. Similarly, the in-hospital survival was better in patients who were in the intensive arm. And also, it was noted that patients receiving intensive care for more than 5 days, they had a better control of glucose. And coming to the secondary objectives, it was seen that intensive insulin therapy, it reduced the incidence of bloodstream infections, acute kidney injury requiring renal replacement therapy, the number of red blood cell transfusion, and the incidence of critical illness, polyneuropathy. Also, intensive insulin therapy reduced the requirement for prolonged mechanical ventilation at intensive care. So the Leuven-1 trial, which revealed evidence of benefit among surgical intensive care units. So Greet Vandenberg decided to do this, replicate this study in the medical ICU. And here around 1,200 patients who were admitted were studied, and the intention to treat group, it was noted that there was no survival benefit in patients who underwent intensive or conventional treatment. But in a subgroup in the ICU where they spent more than 3 days in the ICU, it was seen that intensive therapy definitely increased the in-hospital survival. Also, the weaning from mechanical ventilation, discharge from ICU, and discharge from hospital were better in the intensive arm. So against the background of clinical trials that revealed conflicting evidence regarding possible benefit from intensive glucose control, the NICE sugar investigators conducted a multi-center RCT across 42 ICUs in Australia, New Zealand, and North America. Here, patients were randomized into two groups, the intensive group and the conventional group. And what they found was that the probability of survival is better when the patients were in the conventional group. And death from any cause at 90 days was significantly higher in the intensive control arm compared to the conventional arm. Also, the incidence of severe hypoglycemia was significantly higher in the intensive group compared to the conventional group. So this large RCT, which was conducted across a heterogeneous group of critically ill patients, demonstrated possible harm from targeting normal blood glucose levels. Now, what about the studies of intraoperative intensive insulin therapy? All these studies were done in cardiac surgery patients, and one of them is the trial by Gunjan Gandhi, who did a retrospective observational trial where they found that patients who had at least one composite outcome, they had higher blood glucose, higher mean blood glucose levels throughout the course of surgery. Also, when the mean intraoperative glucose concentrations were measured, it was found that in these patients, it was a independent predictor of mortality as well as pulmonary and renal complications in these patients. The mean intraoperative, there was a linear relationship between the mean intraoperative glucose concentration and the likelihood for a event. Later, Gunjan Gandhi and colleagues also did a randomized trial where they checked the effectiveness of intensive intraoperative insulin therapy versus conventional glucose management during cardiac surgery. And what they found here was that there was not much difference in the blood glucose levels in these patients, but to their surprise, they found that the incidence of death and stroke was higher in the intensive, in patients who underwent the intensive treatment of their glucose levels. So they said that we should be very careful when you implement intensive insulin therapy. Now, coming to the prevalence and clinical outcomes of hyperglycemia in the perioperative period in non-cardiac surgery, it was seen that the 30-day mortality was not different when patients were subjected to whether it was the diabetic patients or non-diabetic patients. But however, the incidence of pneumonia, wound infection, sepsis, urinary tract infection, acute myocardial injury, and the acute renal failure were more in patients who had diabetes. This was a study of around 3,000 patients who underwent non-cardiac surgery. But what was surprising was that the odds ratio for having mortality increased as the mean blood glucose, so the mean blood glucose levels increased. So what we can say from the study is that it was seen more in patients who were non-diabetics. So hyperglycemia in non-diabetic patients undergoing non-cardiac surgery was more dangerous. Now, there are some concerns regarding glycemic variability. Can glycemic variability influence the morbidity and mortality in patients? So this was shown in 2006 by Iggy and colleagues who retrospectively looked both at the mean glucose and the standard deviation of blood glucose as a marker of glucose variability in around 7,000 ICU patients. And they found that both the mean and standard deviation of blood glucose were significantly associated with ICU mortality. Later in 2008, Krinsley showed that the standard deviation of blood glucose level was a predictor of mortality even within different ranges of mean glucose. They demonstrated that glucose variability to be a stronger predictor of mortality than mean glucose. Further defining the effects of glucose variation in an ICU population, Hermanides and colleagues were able to show that the combination of high glucose variability and high mean glucose levels was associated with higher in-hospital mortality. Interestingly, low glucose variability was protective even in patients with high mean glucose levels. Now, coming to the continuous measurement of glucose levels. Now, intermittent measurement of at set time intervals may result in wide fluctuations in blood glucose levels and unidentified episodes of hypoglycemia leading to adverse clinical effects. So, continuous glucose monitoring measures glucose levels probably every few minutes, and they might enable us to efficiently control and reduce the risk of hypoglycemia. Now, what does studies say? This study by Mizu and et al. Compared glucose control using a continuous subcutaneous glucose monitoring system with conventional intermittent point of care measurements. The time in target range of the blood glucose was significantly longer in the continuous group. And however, the duration of hypoglycemia was significantly lower with continuous monitoring, though there was not much difference in the episodes of hypoglycemia. So this study suggests that continuous subcutaneous monitoring may enable better maintenance of blood glucose within the target range with fewer episodes of hypoglycemia. Now, coming to the subcutaneous insulin pumps, now continuation of insulin pump intraoperatively should be restricted to procedures fewer than 2 hours duration. Insulin pump provides basal coverage with a continuous subcutaneous infusion of small doses of rapid acting insulin, and nutritional correctional bolus coverage is achieved by manually pushing a button to dispense the required insulin into the subcutaneous space. If it is not feasible to continue the pump, these patients should be shifted to a subcutaneous basal bolus regimen. It is recommended to administer the basal insulin at least 2 hours before discontinuation of the insulin pump. And this is a very crucial step, and any lapse in basal insulin supply can lead to subsequent rebound hyperglycemia. Nowadays, you have the patient also has a glucose sensor, and it will give you a continuous feedback, and you can modify the rate of insulin delivery. Now, another very important thing is the ERAS, where the patients are given a preoperative carbohydrate load to prevent the development of insulin resistance postoperatively. Now, whether this is acceptable in diabetic patients with type 1, there is no question of giving these preoperative, because it is not going to increase your insulin release. So what about type 2? Now, there are 3 concerns. The first concern is, does preoperative carbohydrate loading delay gastric emptying? Well, studies have shown that there is no, the gastric emptying is the same. Where the second concern is, does preoperative carbohydrate loading increase the risk of hyperglycemia? Well, studies have shown that there is an initial increase which returns to baseline within 3 hours post-consumption in type 2 diabetes. And the third concern is whether whether carbohydrate loading increases the risk of perioperative complications. Well, there was no difference in aspiration pneumonia, 30-day wound occurrence, or wound infections. However, one study has reported a decrease in the length of hospital stay with carbohydrate loading. So It can be given provided it is given 3 hours before the surgery. So summarizing, the target range for blood glucose in perioperative period should be 80 to 180. A preoperative risk assessment should be done for in patients with diabetes who are at high risk for ischemic heart disease or autonomic neuropathy or renal failure. Metformin should be withheld on the day of surgery. The SGLT2 inhibitors should be discontinued 3 to 4 days before surgery. And you should withhold any other oral glucose lowering agents the morning of surgery of the procedure, and give half of NPH or 80% of long-acting analogs or pump basal insulin. You should monitor glucose every hour while the patient is taking nothing by mouth, and the dose with short or rapid-acting insulin as needed. Finally, I would like to conclude by saying that from 1921, when insulin was discovered, we have come a long way, and probably in the future we could have a fully automated closed loop system or the artificial pancreas, which we can call. Thank you.